So I'm going to ask the first question, which I think is a question that is ubiquitous to HRT. So Dr. Goldman, does HRT cause cancer?
Ooh. Okay, how long do you have? So
hormone replacement therapy.
Does hormone replacement therapy cause cancer? The main answer is no. But to qualify that, I think there's been a lot of misinformation out there, particularly about whether hormones cause breast cancer. And where some of that came from is there was a very large trial called the Women's Health Initiative. It was actually the largest NIH-sponsored trial in the country that was designed to see whether hormones prevented heart disease, which is the #1 cause of death. And there was a lot of bad press in 2002 when one part of that trial, one arm of that trial was stopped short with the finding that hormones didn't prevent heart disease and it surpassed the threshold for breast cancer. The press totally took off with the negative results, never really publicized some of the positive results, which was one arm of the study, estrogen only, which is used for women who've had a hysterectomy. You use estrogen and progesterone. If you have a uterus, estrogen alone. If you don't have a uterus, and estrogen alone was actually associated with a lower risk of breast cancer and a lower risk of dying of breast cancer. And that was followed up and published just a few years ago. We've also had many studies since that time. We've learned about different ways of prescribing hormones. We prescribe bioidentical, natural formulations. We prescribe many times patches instead of oral formulations. And what we've learned is many of these formulations are much safer than what was originally thought, and those numbers were really overblown and did a disservice to women. Many people here, we see it every day, people are told from their providers, no, don't take hormones, it causes cancer. And anyone who is trained in medicine since 2002 when that came out really didn't get adequate training in menopause. So we're trying to change that message. I would say that the types of hormones we use are much, much safer. There is increasing evidence that hormones, certainly they don't cause breast cancer, but it's not even clear whether they are associated with a higher risk.
Did you guys hear that? It was that Women's Healthcare Initiative study in 2002, right, Dr. Goldman? Mm-hmm. Do you think that was one of the worst studies ever because it creates so much confusion?
I don't think, it was really the largest NIH-sponsored trial, and it was sponsored because we wanted to see whether hormones prevented heart disease, and that's the #1 cause of death for everybody. I think that the press really did a disservice, and I think that there was a lot of misinformation that came out then and just kept getting amplified and amplified and amplified. And it's taken us a lot of years, more than 20 years, to kind of start correcting some of that information that was published back then.
That's wild, the power of press. Mm-hmm. So if for the women that are in the audience that have breast cancer or had breast cancer or have a family history of breast cancer, what are your thoughts about HRT?
Okay, so when women have breast cancer, and the most common type, 2/3 of women who get breast cancer, it's sensitive to hormones, either estrogen or progesterone, and that means that your physicians will use hormonal therapies to modify the tumor environment. It doesn't mean that hormones in any way cause someone to get breast cancer, but it means they will use hormonal therapies as a treatment. And when you use those therapies, it is considered a contraindication to use hormone therapy on top of that. But the biggest thing I tell breast cancer survivors every single day is do not feel like you have to suffer. We have so many other treatment options that can alleviate symptoms. It's not the same as hormone therapy, which is sort of broad and can take care of many, many symptoms. Sometimes in our cancer survivors, we have to target individual symptoms, but there are many, many treatment options. And if you have a family history of breast cancer, or even if you have a genetic mutation where the lifetime risk of getting breast cancer can be as high as 70%, there is no data that says you can't take hormones. It doesn't mean you don't need to get your close high-risk breast follow-up with getting appropriate screening and doing things you can for prevention, but it does not mean that you can't take hormones. And I think, unfortunately, a lot of women get told that my mom had breast cancer, I can't take hormones, and that's just not true.
So what's interesting is a couple weeks ago, I had a patient come in. She's in her 50s, and she said, I went to the doctor, and he would not put me on medication because I'm going to get cancer. And the first thing I said was, call Midi. And I'm curious, why is there such a discrepancy of the protocol, if you will, with all the different healthcare organizations? It just seems like it would be like standardized procedure that they would just follow, and it would be more streamlined.
Yeah, it's a really good question. I don't know if I know the answer, but I think that it's only been in the past few years that women are starting to change the conversation and asking for appropriate information. And I don't think curriculums, whether you're talking medical school, nursing school, nurse practitioner, PA, have really caught up. So we have data that says only a tiny percent of OBGYN residents have any menopause training, and many times that menopause training is 1 4 to 6 week rotation. That is it in all of their training. So I think that we need to play catch up with people getting appropriate information. And I do think that it's women changing the conversation. Women are saying, I deserve better. And research is being done, and it's slowly getting out there. So I like to think that that's not going to happen in the next 1 to 2 years. I think it still may take a while, but I'm hopeful.
I just got goosebumps because you said it takes a whole bunch of women. I'm looking around this room, right? And I'm seeing a whole bunch of women. It's like a call to action. It takes a village to make these global changes. So as we look around the room, I see women in different decades of life. We have women in the 40s, 50s, 60s, and plus. I'm in my 40s, and so I almost want to break down this hormone by decades. So Dr. Jordan, I'm in my 40s, like I mentioned, and I'm starting to spot a little bit. Otherwise, no other signs and symptoms. My mood seems to be okay, but my husband might beg to differ. I actually asked my husband last night, I'm like, how do you feel? What are your thoughts about my mood? And he says, I just take it day by day. So don't know what that means, but here we go. So I'm in my 40s. A lot of women here are at that age bracket. How do we know if we're in perimenopause?
Right. I think the question is whether women in their 40s would benefit from some interventions, and I would say absolutely, right? So if we talked about the broad spectrum of changes, I didn't talk about brain fog and sleep probably enough, because I think that those are the two symptoms that really begin to hit hard early in the 40s. So there's actually some studies. There's a thing called the Brain Initiative. There's a whole study going on. Lisa Mosconi at Cornell is running this. You actually see changes in your dopamine. You see changes in your serotonin levels. You see changes in your metabolic activity in your brain. You see 2/3 of women having such significant trouble sleeping that it's considered a sleep disorder. So sleep is huge. And then if you think about sleep then exacerbating underlying depression, it can exacerbate ADHD. We see changes in dopamine actually happening, which is that's sort of our executive function hormone. So you'll see ADHD sort of exacerbate, or new onset ADHD, or newly diagnosed in midlife. So there's a lot of symptoms that are not just hot flashes, night sweats. And there's some evidence from that study that it's actually even worse in perimenopause than menopause, actually. So some symptoms are even more profound. I think the skin dryness, hair changes, that tends to be later in menopause. And I'm globally talking because for every woman it's different. So if you're in perimenopause, which most women are in their 40s, about 6% of women go into early menopause, which can back perimenopause into their 30s. They do benefit from interventions. It gets a little complicated because in your 40s and you're still having your periods, you're still fertile. So it depends on if people are desiring contraceptive care and or if they are just wanting symptom control. Because birth control pills do have estrogen and progesterone. So oftentimes you'll see women in their 40s select that as their best treatment because it can positively impact their menopause and perimenopause symptoms while also offering them contraception. I kind of rambled that.
That's actually fascinating because I'm thinking, that might explain a lot about myself, just with the ADHD, like I'm all over the place. How would I know, is that me as a personality or is that perimenopause? How do you discern?
You discern. So
I
the
discern.
patient tell us. Yeah.
Oh.
So most of the clinical data is looking at symptoms and it's not looking at blood levels. So I think that's one of the questions buried deep in there. So remember I showed you the roller coaster. So if I were to test a woman's hormones in perimenopause, I might hit them at the peak and I might hit them at the bottom. If I hit them at the peak, it might suggest that they're not in perimenopause, but they really are. So because we have feedback loops, we start making less estrogen and our FSH pushes our ovaries to make more, so then you get a spurt of estrogen. So blood levels can be helpful to ballpark. Generally, you need 2 or more at different times of your cycle. And then, we tend to lean on them. If you're in your 40s and you have symptoms, you're in perimenopause. You don't need a blood test.
I'm in perimenopause, y'all. Woo! All right.
We sometimes get blood levels anyway because I think numbers can be motivating and people there's something affirmational about seeing them. If you're having perimenopause symptoms in your 20s and 30s, it's also possible. 6% of women is a lot of women. I mean, we're seeing thousands, so that's going to be many of the women we see. I tend to rely on labs then because I think they're out of the norm. But if you were in your 40s with perimenopause symptoms, you're in perimenopause.
I like that you shared that because we talked about shame earlier and it almost releases the shame. Like I'm shifting, I'm changing, I'm noticing, transitions in midlife and it's related to the hormones. So that's really fascinating. For women that are in the audience that are in their 50s, I'm curious, at this age, if they're having symptoms, should they go on HRT or should they wait until they're hit menopause?
I love this question because it's a common misconception in the community that you need to wait 12 months of no periods before you go on hormone replacement therapy. And that is not true, right? So we talked about levels of 300 going down to 10. They don't go there overnight and your symptoms don't wait to start at 10. So they're starting all along the way. And there's a couple commonly held comments that I get from patients at Midi, and one is women in their early 50s start hormone replacement therapy, and so often they say, "Why did I not do this 5 years ago?"
Yeah.
Right? So don't be the person who says, "Why did I not do this 5 years ago?" So I'd say your symptoms are going to dictate when you start, but then at menopause trigger the question.
Okay, that's helpful. Dr. Goldman, for women in their 60s, so just say they're on the estrogen, they're feeling great, their skin's less dry, they're having sex, they're just in a good mood. Can they stay on it forever?
I love that question. And in fact, just an article addressing this came out only 3 weeks ago that talked about the health benefits for women over 65 continuing on hormones. So there used to be, partly from the Women's Health Initiative, concerns that people shouldn't stay on hormones for a long period of time. Part of that stemmed from if there is any association with breast cancer, which we've already talked about that I'm not so clear there is, they saw a higher risk of breast cancer after about 5 years of use. So people used to say use the lowest dose for the shortest duration, and after about 5 years think about coming off. That's changed. The leading menopause society, the Menopause Society, changed their recommendations in 2017 to say people should take whatever dose they need for however long they need for whatever stage of menopause they're in. The second thing that people used to say is you should stop your hormones by age 60 because the risks of hormones outweigh the benefits. And part of that again, comes from the Women's Health Initiative, where we looked at the benefits of hormones depending on different age. So in that trial, because it was designed to look at heart disease as an outcome, they looked at women in their 60s. The average age of people in that study was 63, but the average age of menopause is 51, and most people coming in to talk about hormones are in their 40s and 50s. And it turns out for women in that trial that were within 10 years of menopause or under age 60, the benefits outweighed any of the risks. Lower risk of heart disease and lower risk actually of dying of anything. And that led to what's called the timing hypothesis. So the timing hypothesis says if you start hormones early, we know that the benefits clearly outweigh the risks. You may have a lower risk of dying from anything and a lower risk of dying of the most common cause of death. What people didn't know is, what if you start early and you want to continue? Can you stay on it? And that's what was just published. And we saw for women who started hormones and chose to continue, there were lower risks of heart disease, lower risks of lung cancer, lower risks of colorectal cancer, and for certain types of hormones, lower risks of breast cancer. So we know that there is no reason that people need to stop based on age alone. What we do still need to know, for people who chose not to take hormones because they were given all this misinformation, and then they're in their 60s and they want to know, can I start hormones? For those people, we need to ensure that it's safe. So we need to make sure they don't have the most common cause of death, they don't have significant risk for coronary artery disease, so that their blood pressure is okay, that their cholesterol is okay, they're non-smokers. We now are doing tests called the calcium score that actually can look and see if someone has plaques in their coronary vessels. So all of that is really changing, and the bottom take-home message is there is no reason to stop hormones just based on age alone. You may develop health reasons like you get breast cancer or you have uncontrolled high blood pressure that you need to reassess because hormones aren't safe. But if you are healthy, there is no reason to stop based on age alone.
Wow, that was really fascinating. It almost, when I'm hearing you speak, I'm almost thinking every woman should be on HRT. What are your thoughts? I mean, all the healthcare benefits, for women, I mean, it changes her life.
Yeah, so it's interesting. None of the large guiding organizations in the US have said that women should take hormones for prevention of disease. They all say, if you start within this appropriate time window, that you'll get all the symptom relief, and oh, by the way, it will lower your risk of heart disease and lower your risk of dying, but don't take it for prevention of disease. I think we're kind of trying to change that message. I think we really believe that for the vast majority of women, not just do hormones alleviate symptoms, but they really do help to prevent diseases that you see later in life. That's sort of my opinion. I don't know, Kathleen, probably you feel somewhat similar. But none of the large guiding organizations have gotten there. I'm hoping that they change their recommendations soon so that more people can get a benefit.
Yeah, I think buried in that question is a question about longevity, right? Is it going to make women live better or longer?
And quality of life.
And quality, better and or longer.
Correct.
And we don't have a lot of longevity studies because we used to give people a lot of oral estrogen, and now we use transdermal estrogens. Transdermal estrogens are much better for you, right? So it bypasses, you don't get it. The liver actually makes your clotting factors, so when you take high-dose oral estrogen, it did add this problem risk of strokes and heart attacks that really kind of counterbalance the benefits you were getting from the estrogen. Now we do transdermals, which can be either a patch or a gel. It eliminates that risk and you get all the benefits. So there is a study, I love this study, it's a Cedars-Sinai study, looked at 4,000 women taking hormones for decades. So they were in their 60s and 70s, 30% less atherosclerosis, 30% less mortality at 8 years. So I think if we were to break it down and look at just those taking transdermals, you're going to see much better outcomes. So I think personally, I do think it actually helps with longevity, but I think the data is evolving. So, and I would say the data is evolving and we need to keep watching it.
Got it. Thank you. Then Dr. Goldman, true or false? Can menopause symptoms reoccur in your 70s?
I think it's variable. Certainly we know that the vast majority of people have symptoms in the perimenopausal years and in the early menopausal years, but there's a percent of people, as much as 15% of people, that may persist in having symptoms throughout their life. We also know that symptoms come on related to certain things, so stress can bring them on. So certainly if you have someone who goes through a stressful event in their life, it's possible that they can have a resurgence of symptoms. We also know when we talk about symptoms, oftentimes people are talking about the hot flashes and the night sweats. but there's a whole host of symptoms. Kathleen had mentioned earlier on that slide. I think there's some article I read about 50 different symptoms that people had no idea were really related to hormonal dysfunction. But things like vaginal dryness and urinary symptoms, urgency, frequency, more frequent UTIs, those tend to get worse with time, right? It takes a while of not having estrogen to really impact the vagina, the outside vulva, and the bladder. So there are many, many symptoms that people may not have initially, and then they start developing them more at a later age.
Got it, that's helpful. And just to confirm, if someone's in their 70s, symptoms come back, they talk to their primary care provider, they'll do all the lab works, checking the heart, cholesterol level. If they're clear, then they can go on HRT.
It's still, I think literature is still evolving, but there's increasing data that says if you have someone who is healthy and has no evidence of established heart disease, that there is no reason they couldn't choose to restart their hormones.
And I want to add, even if you, for whatever reason, maybe you've had breast cancer with estrogen receptors, if you cannot take systemic hormone replacement therapy, there's still a lot of benefit to topicals. So there's vaginal estrogen solutions, there's face creams, there's a lot of both hormone topical therapies as well as other therapies that you can treat your symptoms with.
Okay, thank you. So talking about symptoms, we saved this question for last, drum roll, weight loss.
I know.
The midsection that many women go through in menopause. So my first question is, how someone comes into a clinic or speaks to you, they're in their 50s, let's just say, and they're like, I'm going through perimenopause. What's the very first thing I should do, lifestyle modification, if you will, to battle the weight gain?
Oh, Mindy knows what I'm going to say. I'm known for being a big advocate of fiber.
Fiber, that's important.
We made this question last because I could talk about it for a long time.
We'll do that. We'll do a weight loss event.
Yes. So obesity is an epidemic. Midlife women are disproportionately affected. Our metabolism changes in midlife. 40% of women will be tipped into prediabetes. It's the fourth biggest killer of women in midlife. Diabetes.
Wow.
Cardiovascular disease is the biggest killer of women, and obesity is one of the biggest risk factors. So first, I want to make this about health, right? So this is not about aesthetics and looking good for someone else. This is about letting women feel healthy and strong and living a long and great life. So that's sort of how we make that the conversation and really set goals that are going to support best health. And our metabolism changes, so we need help. So some of it's coaching to effective lifestyle solutions. Some of it is going on hormone. So it actually is a risk factor for cardiovascular disease, joint pain. So they are really impactful when used correctly. I do think they should be used with a trained clinician.
Okay.
Because I think what's happened, and I think we need to listen to it, is women can't get it from their doctor, so they're doing it in the back of hair salons. I can tell you from patients that come to us, they're going to Mexico, they're doing it in a not a recommended way. If you escalate too quickly, you're going to increase your side effects, you won't stay on them, right? So I really want women to have access to them through a trained provider.
My concern personally is just, they're not eating as much. That means their protein grams are lower. And in menopause, we're already at risk of osteoporosis. What happens if they stop it and they get the risk of losing muscle density?
You're absolutely right. So this is why I want people seeing a health provider while they're on these drugs. So you get sarcopenia. Sarcopenia means loss of muscle, right? And sarcopenia leads to hip fractures, it leads to frailty, which is a big concern in our next decade of life. 50% of women are going to have a fracture, and half of those women become permanently disabled.
What was the percentage of the fractures again for women?
50% of women will have a
50%, so
Yeah.
half the women in this room.
yes.
If we don't, but we're going to take care of ourselves. So
Right, so you don't want sarcopenia, you don't want frailty,
Yeah.
and then you're eating so little that what you eat really matters. You can't be taking Wegovy and then having half a bag of chips as your only meal. As much as I like chips, that's my weakness. So you do need to lean in and I talk, one of the benefits of working at Midi is we get to talk to these national experts and everything to come up with best practices. People are still figuring it out. We, though, decided that once you're a few months in, we do blood work, we'll check your vitamin D, we check your vitamin B12, we do have people do a 3-day diary on what they're eating, so we do a whole health assessment. You also lose weight, so when you're on these medications, you need to be careful about what you're eating, and you need to be exercising. Mm-hmm. And Mindy always talks about exercise.
I know, and
Please do. I'm a big fan of.
So believe it or not, again, my specialty is cancer survivorship. There is data for women who have had breast cancer that says if you exercise specific amounts, 150 minutes a week, divided times, interval cardio, so push your heart rate, come down, push your heart rate, come down, that it decreases risk of recurrence and improves survival. It is as important as popping a tamoxifen pill or whatever treatment your doctors have you on. And there is now some data that says that same amount of exercise may decrease the risk of getting breast cancer and decrease the risk of getting colon cancer. So we know it's good for our heart, we know it's good for our weight, we know that it makes us feel better, and it also may be protective against certain cancers.
Do you guys hear that?
Yeah.
I'm like the biggest fan of exercise, weight training, and honestly, as I'm in my midlife now, I did work out before my 20s and 30s to look cute, and now, of course, I want to look great. Yeah. And now it's really about quality of life. And so again, when I see my patients come in, they're on this medication, they're not lifting weights, it pains me deeply because I care about all my patients. I'm going, holy crap, you're not eating anything, you're gonna have a hip fracture, you're gonna have some way bigger problems down the line, and if you wanna just be cute right now to wear a bikini at a beach vacation, or you're trying to find a mate for this temporary feeling, the long-term repercussions are too serious to ignore.
Yeah, no, exercise is huge. I was talking about how insulin sensitivity worsens from menopause. So if you exercise, it actually helps your insulin sensitivity. So it exercises your metabolism in a way. So I did an experiment where I did a glucose monitor, and I did my normal thing, which was not exercising, and then and I ate the same breakfast, and then I did a metformin for a day, which a lot of people that's a whole other topic. And then it does help your insulin sensitivity. And then I did an exercise class and ate the same breakfast.
Okay.
And I will say metformin, which is a drug that makes you push out more insulin, my metformin day and my exercise day were the same. So it is a non-pharmacologic way that is so good for you that actually helps your glucose levels and helps your insulin. And my day of sitting and doing nothing and not taking metformin, that wasn't good.
And before we open up for Q&A, Dr. Goldman, since you love exercise so much, I know a lot of these women in here exercise. What are your thoughts between, Barry's boot camp class, weight training, what the heck should these women be doing? Yoga, Pilates, there's so many options now. What's the most optimal exercise as far as vitality?
Yeah, so a couple things. First of all, weight-bearing exercise is what's really important for our bone health. Women actually reach peak bone density between the ages of 30 to 35. Everyone has a decrease after that, but the major rate of loss is in the immediate years after menopause. That can be 2 to 3%. There are specific amounts of weight bearing that is recommended for maintaining maximum bone health, and that's 45 minutes 3 times a week. For longevity and for cardiovascular protection, for cancer prevention, it seems like that interval cardio is what's really important. I'm not sure why that is, if it has to do with inflammatory markers, but I generally will tell people to make sure that they are getting that cardio, and if they combine it with something that provides weight bearing, it allows them to both maintain their bone health as well as get the cancer and cardiac protection.
Our next event, we're actually going to be doing a movement, nutrition, and weight training course, just because I think it's, honestly, should be a prescription.
Mm-hmm.
I'm going to open it up now to Q&A. So how much time do we have due for Q&A?
I'll give you guys 5 minutes.
5 minutes. All right, who wants to go first? Whoa, awesome, I love it.
I'll go row by
Yes,
row.
we
I'm gonna
have to
go.
be
I have
short
one
answers.
right
Okay,
here.
short answer.
Short answers.
Short answers.
Short answer.
My question might be a little long, so I'll keep it short. I'm Anita. Thank you for all the information. So I'm in the 40s group, the early 40s, and like traditional medicine doctors are pushing back on me, asking about questions about perimenopause and preparing myself for that. Then I spoke to a functional medicine doctor, and we talked about HRT. I wanted to keep the option of fertility. So one question is how HRT affects fertility, and the next question is, I'm doing a lot of lifestyle changes, but I don't want to have a bowl of vitamins as part of my meal. And a lot of it is supplementation, as well as exercise. Are there any treatments that I can do that can help relieve symptoms? Because I know supplements, working out, all of that will take time, but talking to a lot of women, we want to see instant gratification to keep us going. So just have that relief in the meantime.
We
So
do both.
thank you.
Let me just start with part of that. HRT does not affect your ovarian function. You can still get pregnant if someone is taking HRT. It is not the same as contraception. Doses of hormones are about 1/3 to 1/5 the dose of what's in contraception. There is also no data that says OCPs, oral contraceptive doses, or HRT impact fertility. The biggest thing that impacts fertility is age. Fertility rates drop off by the late 30s and certainly by the 40s. I don't know if you want to take some of the other longevity kind of.
On which supplements might help, it really depends on your symptoms. If your symptom is sleep, you might want, we would ask you more about your sleep. Is it stress related? Is it waking up in the middle of the night going to sleep? But it may be magnesium, it may be ashwagandha, it may be cortisol manager. So it sort of depends on your symptoms. If you have vaginal symptoms, if that's, then it would be a topical. If it's skin, it would be a different solution. So you don't have to be on hormone replacement therapy, but what we would choose would depend on what your specific symptom was. And there's a lot of them.
And vitamins, we know that after menopause, people need supplemental calcium. You cannot get enough from dietary sources alone. Before menopause, if people are eating a well-balanced diet, we're not necessarily going to tell you to take a lot of vitamins on top of that.
All right, thank you. Next question. Or it says I'm by you, yes, and we're wearing blue.
I wanted to find out what your thoughts are about testosterone replacement for women.
Do that in 30 seconds.
So,
This is it.
thank you for asking that question. So we know that testosterone levels drop after menopause. Testosterone is not FDA approved for women. Part of the reason for that is the studies that actually showed a benefit for improving sexual functioning came on the heels of that very large trial, the Women's Health Initiative, and the FDA said, we want more safety data with regards to the breast, and it's never been FDA approved since then. The best data for the use of testosterone supplement is in improving sexual functioning for postmenopausal women, and large national societies support it. There is evolving data that is looking at it for cognition, for bone mass, for muscle mass, for bone health, for cognition. That is still evolving in the longevity space. People are very, very interested in it. I would say that data is still evolving. There are people that think that women should get testosterone when they take their estrogen and progesterone. My general approach is one thing at a time. You don't know if something causes a side effect, which it's due to if you start multiple things. And we usually see how someone's feeling, and if they need supplemental testosterone, even if it's for one of these situations where literature is evolving, we might add it.
For cancer patients, though, wouldn't testosterone help boost their estrogen level? I prescribe this, so
Yeah,
I'm
a
curious.
little bit controversial. I chair the menopause panel for the National Comprehensive Cancer Network, and we have said that at least for hormone-sensitive breast cancers, that there's probably not enough safety data. Interestingly, there's corollary data that says that testosterone may be beneficial in preventing breast cancer. So I think literature is still evolving. I think for other types of cancers that are not hormonally sensitive, same as we would recommend HRT, testosterone I would include in that with the caveats of what we do and what we don't know.
Perfect, thank you.
Okay, so this is for you. So I'm a breast cancer survivor. Actually, we both are. We just discussed this. and I got diagnosed at 33. So you're seeing the ages drop younger and younger. And when I look at oral contraceptions and how young kids are getting on birth control, do you think there's any correlation there?
Yeah, I think people don't know why we are seeing a higher incidence of breast cancer in younger women, which is women under the age of 50. There's been lots of things proposed, not just the hormones that people are taking. There's been research looking at potential hormonal agents in cosmetics and things like that. I don't think we know. I think that a small percent of people who are diagnosed younger have a hereditary cause, and genetic testing has evolved more and more and more. And we can check for many things that we weren't able to check for even 10 years ago. So I think we're learning more, but I don't think that we have any final answer. And I'm not convinced. The data on the current pills, it's not clear that the current pills increase the risk of breast cancer. There used to be a thought that the higher dose pills that were used in, like, when pills came out in the 1960s, 70s, and 80s may have a higher risk, but it's not clear that the low dose pills do.
Perfect, thank you for sharing. Thank you so much, Nurse Joy. Are you seeing any significant differences between women of color, so Black women, brown women, and white women, and how we go through menopause and some of the symptoms?
Absolutely. We train to it. So Black women will go into menopause earlier, have symptoms for longer. Certainly we see differences in weight, we see differences in vitamin D. The darker pigmented skin is going to have more profound vitamin D deficiencies, right? So there's lots of different changes. There's also different language people use. So for some cultures, actually going through hot flashes, night sweats, and menopause is a rite of passage that women that you're proud of. So you don't ask if you're suffering from hot flashes and night
Is that
sweats.
Asian culture?
Yeah.
Asian people love heat.
Yeah. Right? So you just ask if you have them, right? So there's how you ask, there's when you ask, and there's differences in presentations. So yes, absolutely.
Perfect, thank you. We have time for 2 more questions. Any more? I'll take 2, Nancy.
Hi, Dr. Golden. I just wanted to say that UCSF is amazing, and just the whole team at UCSF for breast cancer collectively is by far the best, period. 2 quick questions. How do you feel about collagen as a supplement? And now I'm having a brain fog moment, I can't remember. Oh, I remembered, sorry. And if you do happen to have an oncology team at UCSF, how does Midi work with that team?
You answer that one.
Okay, that one I can easily answer. So first of all, Midi actually has partnered with UCSF, and we take almost all the same insurers that UCSF does. So I work in the oncology department at UCSF as well as working for Midi. And so it's very easy that we facilitate patients being seen at Midi. Our electronic medical records talk to each other so people can see what's done on both sides. In terms of collagen, I don't know any data that says it's contraindicated, but I also don't know the data on the benefits of it.
Yeah, the collagen data we're working through right now because there's such a disparity in what's offered, so it's very product specific. So we're actually working with specialists over the next 3 months about finding out which supplement is actually best. So I would say it's product specific, not category specific. It's always safe, it's whether it's efficacious.
Perfect.
But if you want collagen in skin, I can tell you about that.
Yeah. Everyone perked up.
Yeah, so topical estrogen has been shown to increase your collagen production in your skin by 30%. It will increase skin thickness and it will actually increase skin moisture. So that topical estrogen for sure helps with collagen in the skin.
And can I just add that even for people who have breast cancer, I know you mentioned this before, but there are plenty of estrogens that people can use. There are certain forms of vaginal estrogen that are considered safe. The topical We prescribe at Midi a topical estriol, and that is not associated with rises in blood levels of hormones, and so those are also considered safe in breast cancer survivors.
Perfect, thank you. Last question before we cut out for break, Nancy?
Now, I'm curious, what I understand, not all estrogens are equal, like where they compound them, some are based out of yam. You know, years ago, wasn't it horse urine that caused a lot of controversy? So I'd like to know more about, because I know there's a lot of compounding pharmacies, but I don't have the background or research to really.
Okay, so it is true, estrogen is not estrogen is not estrogen. And in fact, the Women's Health Initiative that I have gone on ad nauseum about studied a conjugated estrogen that was the one that was produced from mare's urine. It is actually a very safe and still available form of estrogen. We have learned a lot more about different types of estrogen. We tend to prescribe bioidentical formulations which are similar to what our own ovaries put out. There is a lot of confusion about the difference between bioidentical and compounded formulations. So there are many commercially available bioidentical formulations that your insurance will cover. When you go to a compounding pharmacy, they oftentimes make up a formulation that contains different types of hormones, whether that's estrogen, progesterone, and testosterone. Oftentimes they are not standard formulations. They are most often made from natural sources, and so people think they must be safer. But large guiding organizations in this country have said there isn't guidelines, there isn't necessarily control over those. You want to make sure they do third-party testing to assure purity and efficacy. And many of the large guiding organizations in this country will say, if people want to use that, that's fine. But we do not have data to say that those natural compounded formulations are any safer. And our goal is access, and access that is insurance covered. So we prescribe bioidentical formulations that insurers cover.
Yeah, with one exception, which is the testosterone. So testosterone is not made for women, so and we need like 1/10 of what men, so you cannot take a male formulation. So we do lean into compounding for testosterone. But if you're if you have a patch and it's Viveldot or Dottie or a generic estradiol patch, those are bioidentical, actually. So you don't need to do compounding for basic estrogen and progesterone. And then the oral progesterone is also bioidentical. The estrogen and progesterone, and I'm lumping a lot of different products, but most contraceptives, those are not bioidentical. But for traditional hormone replacement therapy, should be covered by insurance, should be at your Walgreens and pharmacy or wherever you go, and are bioidentical. But if you're weaving, a lot of times they want to weave in some testosterone, then compounding is necessary.
Thank you.
You're now labeled as the testosterone person.
Perfect. Well, thank you so much, our panel one, Dr. Goldman, Dr. Jordan, and before we cut into break, sorry, I cut into your breakdown a little bit, but before we start, what is your lucky number before we leave for break? Lucky number.
I'm going to go with 7.
Number 7. Do I have a Melissa Carson here? Melissa. Oh, sorry, but you want a bag. Sorry, I pronounced your last name really small on this. So sorry. Okay, Dr. Jordan, what's your lucky number? Anything. Joy, get ready. What's
1.
Number 1. Okay, number 1. Liz! Yay! You have a number, Joy?
Yes, 8.
Number 8. Let's see. Anita Chan. Groceries, right? Or some dumbbells. All right, my lucky number today is number 30, Felicia Garcia. Woo!